morning and welcome to today's CME activity. There is no commercial support. The speakers and planners have disclosed no relevant financial relationships with any commercial interests.
Recording in progress.
A SurveyMonkey link after today's activity. And if you're viewing online, we'll list that link into the chat section. Also, if you are here and you're not a resident and you would like for NGHS to report your CME credits to the ABS, you will need to fill out the evaluation and give us your information and approve us to do that. It is my pleasure to introduce Dr. Machado, who received her medical degree from Kirksborough Medical College in Manipal, India, and completed her residency in general surgery at Case Western Reserve University, University Hospitals of Cleveland. She then practiced general surgery at University Hospitals Connaught for 3 years, and subsequently completed fellowship training in endocrine surgery at Yale New Haven Hospital. Her practice focus includes benign and malignant thyroid, parathyroid, and adrenal disease, as well as an interest in resident and medical student education. Join me in welcoming Dr. Machado.
All right, good morning, everyone, and thank you, Jennifer, for that introduction. So my name is Nikita Machado, and today we're going to be talking about molecular testing in thyroid disease. We're going to talk about it from a surgical perspective, but we're also going to realize just how much interplay there is between endocrine surgery and a number of other specialties when it comes to treating thyroid disease. We'll talk about what's new, we'll talk about what's upcoming, and the most important thing, first and foremost, is I am a surgeon and I love history. So before we get started, I would love to take you back a little bit to see how far we've come before we talk about where we're headed in the future. Now, a lot of you may or may not be familiar with this quote, and if you're not, you really should be. Before the turn of the 20th century, surgery was considered the practice of barbarians, to be fair, and none more so than when it came to thyroid surgeons, to the extent that this gentleman, Sam Gross, said that no sensible man would ever consider taking out the thyroid gland, because the sheer act of doing that would be tantamount to butchery. It's understandable why he thought that. Thyroid surgery was fraught with complications at that point. There was no really good way to control hemorrhage. The mortality rates were sky high. Asepsis and antisepsis were not concepts that anybody was familiar with. That was going to change over the next 30 to 40 years with the people that you see here. So Theodore Billroth was the first of many. He's a world-famous surgeon who performed the first esophagectomy, the first laryngectomy, the first gastrectomy, and even he was felled by thyroid surgery. He had an initial mortality rate that approached almost 40%, and he had a recurrent laryngeal nerve injury rate that approached 25%. It's almost unthinkable in this day and age, but they operated obviously in a different time. He was followed by Theodore Coker, and I can safely say that endocrine surgeons today owe a lot of what they do and who they are to this man. His initial mortality rate of 14%, he was able to bring down to 0.18% at the end of his career, and that is incredible considering when he operated. His recurrent laryngeal injury rate was down to 1%, and that is the gold standard that I quote patients today. And I think in big part the reason why he was able to do this is because he adopted and followed a set of surgical principles that were anatomically sound, and they make sense for us even today. Be very meticulous in your dissection, make sure that you preserve the nerve, make sure that you preserve the parathyroid glands, and then give them the thyroid hormone that their body is going to need once you take the gland out. It sounds obvious now, but it really wasn't at that point in time, and he was a pioneer in endocrine surgery. And it's for that reason and many more that he actually got the Nobel Prize in 1909. Finally, William Halsted. We know this gentleman because he is credited with starting the general surgery residency the way that we know it in the United States. Granted, it looked very different in his time. It was brutal, it was pyramidal. A lot of people didn't make it through residency to become attending surgeons, but he gets the credit nonetheless. And he is reported to have said that the surgical removal of the thyroid gland, more than anything else, exemplifies the supreme triumph of the surgeon's art. And when you think about where we started doing thyroidectomies to where we are today, where it's an outpatient, efficient, safe procedure with a very low complication rate, you start to see what he meant. All right, so today we're going to talk about molecular testing in thyroid disease, and I find it always helps to give yourself just a little bit of context when you start. Thyroid nodules are everywhere, and we know this. The palpable nodules, the ones that are found on physical exams in clinic, may be 4 to 7% of the population. The ones that are much more common are the ones that are found incidentally on ultrasound. And this could be anywhere from 19 to 67%. We see them on CTs, MRIs, ultrasounds, you name it, and there is a way to incidentally find a thyroid nodule. However, out of this big bucket of nodules, maybe only 5% are eventually going to be found to be malignant. So when we look at a thyroid cancer incidence of about 13.9 per 100,000 people, women more common than men, it begs the question of where is that fine line between overdiagnosing and overtreating every nodule that comes your way to missing something that could potentially lead to local recurrence and complications down the road. It matters even more so when you realize that thyroid cancer outcomes are generally great. There's a 98.5% 5-year survival, which means that for these patients living with local recurrence, the HPP surgeon in the room is smiling at me because his 5-year survival rates do not look like this. But, when you have a cancer like this, it's important to make sure that we're not setting them up for local recurrence and complications in the future. So, molecular testing. It's had a long, kind of bumpy road, but the breakthroughs in between have been phenomenal. It started way back in 1993 when we discovered the RET mutation. And the RET mutation is commonly seen in medullary thyroid cancer. Some fusions are seen in PTC. But the wonderful thing about this is when they found this out, they were able to parse out the difference between familial and sporadic medullary cancers. What that meant was you could find familial kindreds, you could find people who were not yet affected and offer them a prophylactic thyroidectomy so that they never got medullary thyroid cancer. And that was a phenomenal breakthrough. In 2000, we found the PAX8 PPAR gamma fusion, and this is something that you see more so in follicular thyroid cancer compared to medullary cancer. They obviously behave very, very differently, and so it's great to have that molecular signature up front to know what you're dealing with. 2003, in my mind, is a banner year for thyroid cancer genetics because this was the year that we discovered the BRAF family of mutations. And BRAF V600E is one of the most common driver events for papillary thyroid cancer. You also see this in dedifferentiated thyroid cancers and some more advanced forms. And all in all, I would say you see it in about 50% of papillary thyroid cancers. And this is a big number. Finally, and this is just over a decade ago, so realize how recent this is, there were a few back-to-back articles that reported this TERT promoter mutation for the very first time, and they first discovered it in melanomas. They very quickly found that the TERT promoter mutations could also be seen in thyroid cancers, especially in advanced forms, in dedifferentiated cancers, and in anaplastic thyroid cancer, which as we know are some of the most aggressive kinds of thyroid cancer that they are. So the goal always is to find other potential causes. Can we come up with a comprehensive list of genomic sequences that will help us to predict what thyroid cancers are going to look like and what they're going to behave like? Now, I don't know how many of you are familiar with the Cancer Genome Atlas. It's this amazing collaboration between the U.S. National Cancer Institute and the National Genome Research Institute. They started this sometime in 2006, and the goal back then was to look at these landmark genomic, epigenomic analyses so that we could analyze all the major types of human cancers. What you see up on the screen here is the Thyroid Cancer Gene Atlas, and this was published back in 2014, and it was quite a breakthrough at the time. There's a lot on that slide, but what I really want to draw your attention to is that you can divide papillary thyroid cancer into 3 groups based on the RNA expression. So on the left side, you see all the BRAF-like tumors. On the right side, you see all the RAS-like tumors. And then there's a third category, which we call non-BRAF, non-RAS, and they behave in a separate fashion from those two. This matters because based on molecular signature, they look different under the microscope. So if you have a patient who has a RAS-like mutation on the right, they tend to be follicular-derived cancers. If you see patients with a BRAF mutation on the left, that's all the blue, those are classic papillary thyroid cancers. And while there can be some overlap, as you see in between, for the most part, they are distinct and they behave differently. So when we talk about the current molecular testing landscape, what do we look for? There's a number of different testing kits out there, and they all look at some of the same things. Number one, they can look at DNA, which is sort of your original database of instructions. They can look at RNA, which is downstream of that, and basically helps to iterate different versions of functional proteins. Or they can look at microRNA, and these are regulators that upregulate or downregulate the way that RNA expresses itself. The kits can look at 2 of these, 3 of these. It just depends on what it is that they're testing for. And before we talk about what the molecular testing kits look like, I think it's really important to emphasize just how much your cytopathologists matter. We talk about not being in a vacuum, and endocrine surgery cannot exist without good cytopathologists, good radiologists, and good endocrinologists. The cytopathologist role when we start out is to help us define, at least to some extent, how concerning something is for a cancer. This brings us to the Bethesda system, where you can go anywhere from a non-diagnostic Bethesda 1 to a biopsy-proven Bethesda 6. Some of this is fairly simple. If you have a 1, a 2, or a 5, or a 6, you already know what to do with these patients. You're either going to repeat your biopsy, you're going to do nothing because it's benign, or you're going to take them straight to surgery because you have a higher than average index of suspicion for a cancer. The place where molecular testing really shines is with 3s and 4s, because we know here that your cancer risk is anywhere from 5 to 30%. It may not be enough to justify taking a patient to the operating room, especially in the absence of other risk factors. And so when you introduce molecular testing here, it gives you an easier way to get some clarity and maybe to help you with that individualized decision making. So there are 3 main commercial kits that I want to talk about. We don't have all of them here, but I think it's important to know the differences so that you can know what makes most sense for your practice. The first one that I'm going to talk about is Thyroid. I will start with this disclaimer. The kind of kit that you use at your institution is often institution dependent, and secondarily, it's provider dependent. So you may find variances in different cities across the state. Now, Thyroid was actually developed at the University of Pittsburgh. It was a group of endocrine pathologists and endocrine surgeons who came up with this, and it's about 112 gene sequences that they look at, and they look at all the obvious alterations in thyroid cancer. What I love about this is that you will either have a negative test result, as you can see on the screen, or you will have a positive test result. Some of the other tests have intermediate suspicious results, which we'll talk about in a little bit. But the great thing about negative or positive is it's a much easier discussion to have with your patient. You don't have to then tell them, well, it looks suspicious, but I'm not sure, and I might have to do additional testing to prove to you how concerned I am. Here, based on whether it's negative or positive, you'll get a probability of cancer. It'll give you their idea of what the tumor type is. And then, even though it's not the end-all and be-all, they will try and help guide patient management based on what kind of mutation they see in the molecular signature. The one that we use here at Northeast Georgia is Afirma. It's the original molecular testing kit. And when it started out, it used to be called GEC, and I think they looked at about 150 genes. They've now iterated multiple versions of it, and the newest one called GSC looks at about 500-something genes, multiple fusions, and things like that. It's good, but there's something that I want to point out to you here. So when we look at the screen, you see that Afirma GSC is your test. You can either get a benign result, which means your risk of cancer is basically the same as the average population, or you can get a suspicious result. Suspicious means that there is a 50% risk of malignancy. And I don't know about you, but to me, that's a little bit of a coin toss. So at that point, you have a few options to discuss with your patient. You can tell them, hey, your risk of cancer is 50%. It's more than it should be for a Bethesda 3 or Bethesda 4. And you can opt to take them to surgery and at least do a lobectomy. What you can also do is a secondary test called Afirma Expression Atlas. This is newer, and the reason that I bring it up separately is because it does not get sent with the original test. So if you want this information, you have to basically order it on the back end. They do get charged separately for it, I believe, the last time I spoke with the Afirma rep. And Afirma Expression Atlas then looks for all those other detailed mutations that we talked about in their concerning nodules. So some people say that's a good thing. I kind of like having that information up front. But you can then use Expression Atlas to tailor your treatment. And finally, we have Thyroid Next Thyromere. This is newer. And here they have what they call a unique 3-category reporting system, which basically means, again, you can have something that's benign, indeterminate, or malignant. And in the obvious cases, we know what to do, right? If it's benign, you're going to follow them. If it's malignant, you're going to operate. For the ones that are in between, though, that are indeterminate, they also use additional microRNA testing to help you figure out what your risk is and whether they would benefit from surveillance or surgery. So now that we have all these testing capabilities, how do they stack up? There's been a lot of studies that have looked at head-to-head comparisons of the different genomic classifiers. The study that you see on your top left was one of the first ones that was done. It was a prospective multi-center study, came out in 2018, and they found that Thyroid was superior to Afirma in the testing that they did. I will add the disclaimer that this was published in 2018, and the new version of Afirma only came out in 2017. So to be fair to them, I don't know that they had enough data at that time to point that one was superior to the other. In 2020 was another study that was done in the opposite end of the country. They did the same thing. They compared Afirma and Thyroseq side by side, and they actually found that they were fairly comparable. And I think this might be including Expression Atlas as part of that workup. And then finally, let's pick a study that was done outside the country. So they, in 2021, looked at comparing Thyroseq, Afirma, and then the microRNA panel that we just talked about. And they actually found in their study, they looked at 40 eligible studies and about 7,000 different nodules. And in this paper, they found that Thyroseq version 3, which is the latest one, showed the best overall performance, followed by Afirma GSC, followed by older versions of Thyroseq and Afirma, which does check out with what we've been talking about so far. There's not enough long-term data on Thygen Next and Thyromere, but whatever preliminary data they have does look promising at this point. So it's easy, I think, for me to stand here and say, let's molecular test everybody. It's wonderful to have this information. But I think in the era of providing good quality care to patients, we have to ask, what's the bottom line and how much is this going to cost? Does it make sense for me to order this test for my patient? Is it going to change anything that I do? And so one thing that I try to look at is, what about the cost analysis? Does it make sense to use this? We found that on average, a total thyroidectomy costs about $11,000 to do. If you consider doing a lobectomy and then doing a completion down the road, that number bumps up to about $20,000. The cost to do molecular testing, depending on the test, can be anywhere from $3,500 to $5,000. And I think in this regard, Thyroseq may be cheaper. Then you have to factor in the cost of doing FNAs if your first one is non-diagnostic. And then what if you choose not to operate? What if you just choose to follow these patients with ultrasounds year on end? There's a cost to that too. And what they found at the end of all of this is if you have a reasonable index of suspicion based on your imaging findings and your initial cytopath, molecular testing is great. It helps you save them a secondary operation in the future. It helps you decide if they need an operation. And then it reduces the risk of those come back and complete thyroid lobectomies that we were talking about. So, as a surgeon, how does this matter to us? I think for me, I look at it in 4 different ways. Number 1, is this going to help me identify those aggressive tumors up front? And that sort of ties into point number 3. If I can identify bad actors up front, can I tell what extent of surgery I'm going to need to do? Am I going to be okay just doing a lobectomy? Do I need to be prepping them for a total thyroidectomy? Do I need to be doing a central lymph node dissection on these patients? And should I be worried about the lateral neck? Because does that signature tell me that there's a chance they have metastatic disease over there? The converse of that is, can I spare them from any unnecessary operations? Do I need to be operating on all these patients? And finally, for those cancers that are extremely aggressive, that end up de-differentiating so they don't even behave like normal, well-differentiated cancers anymore, can I use that molecular testing to help drive targeted therapy? And the answer for the most part for all of these is yes. But for me, when I'm talking about how I'm going to decide how much surgery to do on a patient, it's always a multidimensional assessment. Demographics matter. Age matters, gender matters, and to some degree, so does your environmental exposure. I'll give you an example. We have an amazing oncology nurse here named NGPG, and she showed me this data that said that the rate of incidence of young thyroid cancer, so we're talking age 20 to 40, in Hall County and Habersham County is higher than the rest of the state of Georgia, which is a little worrisome. These are young patients with advanced thyroid cancers, and either there are some familial kindreds that we're missing. The most likely explanation is that there's an environmental factor at play that we haven't yet figured out. And so it just drives home the point that the environment matters. Imaging matters. The suspicion that your radiology colleagues have based on their ultrasound, that makes a difference. So does cytology. Like I've told you with the Bethesda classification, cytopathologists are telling us up front how worried they are that something might be a cancer. And molecular testing, while it's great, is just a part of that puzzle. And all the risks are additive when you put them together. For me, in addition to all of this, I also look at other things when I'm deciding how much surgery to do on a patient. Do they have a history of radiation exposure? Did they ever get mantle cell radiation as a child? Do they have a strong family history of cancers and other thyroid issues? And what about patients who are already on Synthroid or already have a high TSH level? The whole point of doing a lobectomy is to spare some thyroid tissue to give them a chance at normal function. With these patients, that ship has already sailed. So I might as well offer them a total thyroidectomy to mitigate their cancer risk because I know that I'm not going to be able to prevent them from needing Synthroid in the future. And finally, and this is a big one, patient preference. There are some patients who will tell you, that they would much rather have the whole gland out. They don't want to deal with the anxiety of having to follow this thyroid over time, have a risk that the other lobe may develop cancer. And there are others who say, I do not want to take a pill for the rest of my life. I would much rather assume the risk of you taking out half the thyroid now if it's oncologically feasible, and then we'll come back and fight another day if we need to. And it matters. So ultimately, what that ends up at is it has to be the correct operation for the correct patient at the right time. And I think molecular testing is one piece of the puzzle that helps us to do just that, which is individualized patient care. So let's talk about the real world for a second. I have a couple cases up here that show how molecular testing can change the way that we do things. So let's take this patient. She's a 50-year-old female. She has a 1.9 centimeter left-sided solid thyroid nodule, and she's asymptomatic. She ends up getting an ultrasound, and based on her ATA classification initially, it's a reasonably low-risk image. We do an FNA, as we always do, and this returns as a Bethesda 3, or an atypia of unknown significance. As we do then, because it's a 3, she goes to molecular testing with Afirma. And this time, it comes back suspicious, which means if we remember, somewhere around a 50% risk of cancer. So what do I tell her? Usually, we tell this patient one of two things. This is a 50% risk. We started out when you were a Bethesda 3 with maybe a 5 to 15% risk of cancer. We added another layer of testing, and I can now tell you your risk has gone up to 50%. That's enough for a lot of patients where they will say, let's do a lobectomy, let's mitigate this risk. It's already high enough for me. There's a 1 in 2 chance that I have cancer. But is there more? If we did that expression atlas that I talked about, which is that secondary test, we do this in this patient and it now shows a whole different picture. It shows me that she has an NTRK3 fusion. NTRK3 fusions can be associated with more advanced thyroid disease. They can be associated with lymph node disease and more aggressive cancer. So does that change what I do? It absolutely does, because now I'm telling this patient from, oh, your risk of cancer has gone from 5 to 15% to 50% to now 95%. So all of this information is staggering her risk and telling me we need to talk about, does it even make sense to do a lobectomy? Should I be considering a total thyroidectomy in you with this new information that I have? And so molecular testing can change what you do for your patient. Let's take another case. So she's 44 years old this time. She has a 3.2 centimeter solid nodule. You do the ultrasound, and it shows you that she's got an intermediate risk. We do the FNA, and this time it comes back as a biopsy-proven papillary thyroid cancer. Like with all these patients, we do lymph node mapping for the lateral neck. We don't see any lymph nodes. It's all good. So now when I talk to this patient, the discussion changes a little bit. When they have a proven cancer, if the nodule is bigger than 4 centimeters in size, I routinely will recommend a total thyroidectomy for them, just because at that size, with that cancer, they will need radioactive iodine. If it's a really small cancer, less than 1 centimeter, I tell them you're probably fine with a lobectomy, and for the most part, they will be. It's those in-between cancers where the decision has to be a little individualized. And so now this is a 3 centimeter cancer. Could we do a lobectomy on her? Possibly, we could. Is there a chance that I might have to come back and do a completion? Also, yes. So is there a way to clarify that a little bit more? If we had done molecular testing on that sample, and it came back with one of these two options, the management changes. If it came back as a BRAF V600E mutation, that's an more aggressive tumor. It has a risk of lymph node involvement. I am telling this patient that I think that she should have a total thyroidectomy based on her risk profile with what I now know. On the other hand, if it came back as a Paxade PPAR gamma mutation, that's associated, like we talked about, with follicular thyroid cancers. The risk is a little lower. And in that patient population, she might still be okay to undergo a lobectomy and surveillance as opposed to a total. So again, the more information you have, it is better depending on the clinical context. And finally, let's talk about this gentleman. So he's 19, he's young and has this self-detected neck mass. The ultrasound here shows, again, 3.5 centimeter solid nodule. He's got 3 abnormal lymph nodes. We biopsy the tumor and the nodes, and they come back positive for papillary thyroid cancer. So we know that this guy is having a more extensive operation. He's going to get a total thyroidectomy, he's going to get a central lymph node dissection, and he's going to get a lateral lymph node dissection because he's got those lateral neck nodes that are positive. On his final path, he ends up having 12 positive lateral neck nodes. So this disease has spread. And then as part of his workup, he gets a whole body scan. It lights up in the lungs. They do a CT, and this shows multiple lung nodules. So now we are talking about metastatic disease in a 19-year-old. So here's the question. We already know that this is thyroid cancer. We know that he's going to need adjuvant therapy. Is there any point to doing molecular testing on that surgical specimen that we took out? And the answer here, again, is yes. Because when we do a molecular analysis, you come back with a RET fusion as your primary tumor driver. Why does this matter? Because this is targetable. This is actionable. And so for this young 19-year-old, not only can we give him RAI therapy, we could also potentially give him targeted immunotherapy against that RET fusion. So again, the information stacks up, and the more that we see and the more information we have, the better able we are to treat these patients. So we've talked a lot about diagnosis, and clearly we see here that molecular testing can help. But can it help prognosticate beyond that? And so if you remember, we had looked at the thyroid cancer genome atlas, and we had split these tumors into BRAF-like, RAS-like, and then the third category, which is non-BRAF, non-RAS. There's a great paper that came out in 2020 that looked at splitting them into these three groups, and they analyzed about 570 thyroid cancer cases. When they did that, they found that if your tumor was more likely to be a BRAF-like tumor, you had a higher incidence of lymph node disease, extrathyroidal extension, lateral neck disease, local invasion, and to some degree distant mets. So these are aggressive tumors, which means if you can see the kind of molecular signature they have, you can tell the patient you are more likely to have this type of disease. The specific alterations that you see with those different kinds of tumors, you see down below. So if you look at the NTRK fusion, which I was talking about with, I think I did that. There we go. If you look at the NTRK fusion that we're talking about over there, it actually overlaps with both BRAF and RAS-like tumors. So they can be fairly aggressive. All the BRAF mutations are here, including that RET fusion in that 19-year-old patient. All the RAS mutations are over here, including a wild-type BRAF. And then you have these other random mutations like DICER and IFAX that are neither one nor the other, and they actually behave fairly well. All right, now this I found really interesting. So we talk about how molecular testing can show you a difference in prognosis, but again, it's important to remember that it doesn't work alone. Meaning, if all other things are negative and you have a BRAF mutation, it does not mean that you have a worse prognosis. If you have a at-risk patient based on their histology and they have a BRAF positive mutation, then it makes sense. Then those patients tend to have a lower recurrence-free survival, they tend to have worse prognosis, and they tend to do worse than patients without a BRAF mutation. But this stacks up. So let's say I add a TERT promoter mutation to that. So not only do they have a BRAF mutation, they now have a second mutation. As you can see here, those patients also do worse in the long run. So compared to their cohorts, they will have a higher risk of recurrence. And then finally, the trifecta. Let's say they have BRAF, they have TERT, and they have a RAS mutation. It's always an incremental and synergistic effect. And so for those patients here, you can very clearly see their recurrence or the disease-free survival is significantly lower. Now what we know is that Hürthle cells are actually different cells. They have a higher amount of mitochondria in them. They have these large cytoplasms, as you can see on the side. And you can see Hürthle cells in inflammation, you can see it in benign goiters, and you can see it in cancers. The most important thing, though, is that we now know that they are completely molecularly distinct from other thyroid cancers. They will have mitochondrial alterations and copy number variations instead of the mutations that we see with follicular thyroid cancer and papillary cancer. This makes them a little tricky to detect with molecular testing. Because like we talked about, when they started this whole process, they were looking at the drivers that we commonly see in follicular and papillary cancer. It is getting better, though. So now that we have upgraded newer versions of our molecular tests, it has gotten a little bit easier to identify the potential for a Hürthle cell carcinoma. We're still working on it, though. I think their sensitivity is anywhere from 80 to 100%, depending on which test you look at, and the specificity is anywhere from 60 to 80%, again, depending on which test you look at. So we do have a long way to go. And finally, what about those advanced thyroid cancers that we had talked about? The gold standard of treatment before used to be take the thyroid out, and then you may or may not need to give them RAI in the future. With metastatic disease, that does change because a lot of these tumors can start out well differentiated, and then they become de-differentiated with time. So they don't behave like tumors that will respond to RAI. And this is a problem because now one of the tools in our arsenal no longer works. So these patients end up needing alternative therapy, whether that's local regional, in that case we're talking about external beam radiation, or systemic therapy with targeted treatments. So in an advanced thyroid cancer, in my mind, the main goal is to detect something that we can affect. So we want to detect a targetable alteration. And based on that, identify what's going to work for that set of patients. So some examples of those actionable targets that we talked about are things like BRAF, RET, NTRK, ALK, and mTOR. And we've seen a lot of these in the cancer cases that we just talked about. So it's good news for us that we have targets that can work on them. On the right, you see this sort of algorithm that talks about some of these advanced thyroid cancers. So if you start with somebody who is RAI refractory and they already have advanced or metastatic disease, or if they have anaplastic thyroid cancer, you can then start looking for those actionable targets that we talked about. Once you find an actionable target, you can see here that there are very clearly different treatments that are targeted for that specific mutation. And to give you an example of what that might look like in the real world, when I was in fellowship, we had this patient who had a very, very large metastatic thyroid cancer. It was a big, bulky tumor that was wrapped around the carotid artery, wrapped around the IJ, and it extended retrosternally down past the clavicles. In addition to this, the patient had bone disease and the patient had lung mets. Ideally, the treatment would have been to give this patient RAI, if you could, but with a tumor that was that big and bulky and still in place, it was not going to be feasible because the RAI would have caused a whole lot of side effects, swelling of the thyroid gland, things that were just not appropriate. The other option in this case would have been to just give them systemic therapy and let them be. But because we wanted to try and give them both RAI and targeted therapy, we actually shrank the tumor with neoadjuvant targeted therapy. It's not something that's described in the literature very often. I think they're starting to do this in trials in some centers now. But we gave that patient lenvatinib, which is basically a tyrosine kinase inhibitor, for about 3 months. That tumor shrank. It shrank so much that it was no longer around the carotid. It was no longer around the IJ. All of that retrosternal extension disappeared and it became a much more manageable tumor. So we were actually able to take that cancer out 3 months down the line and then treat that patient with RAI and treat them with another round of lenvatinib. So you can see how giving them this kind of targeted therapy can actually help us do our operations better, which then gets them to adjuvant treatment faster. And finally, what's left? A lot. So even though I say that we've been doing this for 30 years, there's still so many places that we have to go. We've talked about having these RAI refractory tumors that just don't respond to radioactive iodine. Well, what if we could find a signature that would allow us to flip that switch on and off? And so if you had a tumor that didn't respond to RAI, what if you could flip a switch and make it RAI avid? And so you could then treat those patients with radioactive iodine. There's another set of tumors called NGPG. They used to be called encapsulated variants of papillary thyroid cancer. And cancer is a scary word, so whenever patients heard that, they assumed that it was a bad thing and they needed their whole thyroid out. We now know that they're non-invasive, so they're almost like precursors to thyroid cancer. And so if you do a lobectomy for these patients, now it's more than enough. What if we can find signatures that tell us, yes, this is a NGPG, this is nothing else, you don't have to worry about this tumor, or lobectomy is all you need. And then finally, for distant metastatic disease, it would be great if we're able to find this early on and do something along the lines of that targeted neoadjuvant therapy that we talked about, make these tumors smaller, operate on them, and then continue with adjuvant therapy. So even though I think we've come a long way, I think there's still a long way to go. Dr. Jackson took all our good family pictures last week, so I'm going to leave with this. I'm happy to answer any questions, and I'm happy to talk endocrine with anybody that's interested. Thank you.
Thank you, Dr. Machado. Do we have any questions or comments in the room?
These were all somatic mutations you're talking about, correct?
Correct. So there are some like P10 that can be both somatic or germline mutations, but a lot of these are somatic mutations.
Okay, can you talk a little bit about the familial stuff? And like
Sure.
Who needs working up and who doesn't and this kind of things?
Yeah. So the familial stuff may not necessarily depend on molecular status some of the times. Like we get this with early genetic testing through familial kindreds. One of the examples of that is something like familial PTC. It has its own set of mutations that are separate from the ones that you see in sporadic papillary thyroid cancer. Another example, like we said, is familial MTC. And so some of those RET mutations that we see will be specific to a familial variant of medullary thyroid cancer, while others are seen in the sporadic kind. Oftentimes we have databases for these familial kindreds that will help us kind of isolate them and track them through generations. And then, like we talked about, it allows you to do prophylactic surgery for some of them.
All right. Thank you, Dr. Machado.
Of course. Thank you.
Excellent.